Hi guys, Assalamu alaikum. My name is Anis Fatma and I'm a final year medical student, and today we will be studying about abdominal and inguinal hernias. Note that these surgery lectures are compiled from the Irfan Masood and Brilliant Love. So, what was the indirect inguinal hernia? Indirect inguinal hernia is the hernia which is located in the inguinal region and is lateral to the inferior epigastric artery, or you can say it is lateral to the Hasselbeck's triangle, and often protrudes through the deep inguinal ring which is located laterally, and it is most common hernia of all, especially very common in the young adults. Then inguinal hernia in the childhood are always indirect. It means they would emerge from the deep inguinal ring due to its patent processus vaginalis. It is bilateral in 12% of the cases, and it is more common on the right side. Right side is where the liver is located. Then it affects males 20 times more as compared to the females. There are several different types of the indirect inguinal hernia as well. What is indirect inguinal hernia? It is the hernia which is emerging from the deep inguinal ring, and it is lateral to the Hasselbeck's triangle or lateral to the inferior epigastric vessels. So there are different types which include babonocoeli, funicular, and complete. So the first type is when the hernia is limited to the inguinal canal. It is not coming out of the superficial inguinal ring. And then funicular is the type of hernia that comes out of the superficial ring. Remember that deep inguinal ring was located laterally, then there was this inguinal canal, and then on the medial side there is this superficial inguinal ring. So if it is not coming out of the superficial inguinal ring, it is babonocoeli. If it is coming out of it, it is funicular, but it fails to reach the bottom of the scrotum, and the processus vaginalis is closed just above the epididymis. And then there's complete, the hernia that reaches to the bottom of the scrotum. The testes would appear to lie within the lower part of the hernia. Now, if you're thinking about any swelling that might be the indirect inguinal hernia, there can be the several different differential diagnoses of it, right? In the males, it could be vaginal hydrocele, or it could be encysted hydrocele of the cord, or it could be the spermatocele, or it could be the femoral hernia. While in females, it could be the hydrocele of the canal of Nuck, or it could be the femoral hernia. Femoral hernia is common in both males and females. And then we are obviously looking at the treatment of the indirect and the direct inguinal hernias. So, operation is the treatment of choice always, because there is a swelling, there is a defect in the anterior abdominal wall, we have to repair that defect. There are two options, that could be the herniotomy or the hernioraphy. So, herniotomy is the procedure which is required in the infants, adolescents, and the young adults. Herniotomy is what? Herniotomy basically involves the dissection and the opening of the hernial sac, reducing any contents which are present inside the swelling, and transfixing the neck of the sac and removing the remainder. So, what you are doing, you are just making a hole, you are just fixing the contents which were inside, and you are closing it, and you are strengthening the wall with the help of some sutures, etc. But then the other procedure, which is herniotomy plus hernioraphy, it is the procedure which is required in adults who have the weak interior abdominal wall. And hernioraphy involves the repair of the posterior wall of the inguinal canal, and mostly we are using the mesh for the hernioraphy procedures. Herniotomy is when we are giving the incision, we are transfixing the contents inside, we are reducing the contents, and when we are transfixing the walls, right? So incision is given 1.25 centimeter above and parallel to the medial two-thirds of the inguinal ligament. You know, the inferior boundary of the inguinal canal is formed by inguinal ligament. You are going parallel to it, or medial two-thirds of the inguinal ligament, which is towards the pubic tubercle, 1.25 centimeter above it. You will slit along the fibers of the outermost muscle of the abdominal wall, which is external oblique muscle, till where? Till the superficial inguinal ring. You will identify the ilioinguinal nerve and preserve it. It's very important because it's supplying all the structures in the iliac region, in the inguinal region. Then identify the spermatic cord and incise the external spermatic fascia which is covering the cord. Divide the cremasteric muscles, protect the cord with the tape or hernia of the ring. You will inspect the contents of the spermatic cord for the presence of the hernial sac, which appear as pearly white structure on the outer side of the cord. You will hold the sac with the clips and separate it from the spermatic cord structures as far as the deep inguinal ring is present, which is present laterally. Open the sac, release the contents into the abdominal cavity, and transfix the sac close to the deep ring as high as possible, and divide just distal to the ligature. So, in conclusion, the only thing you need to remember about herniotomy is it is 1.25 centimeter incision above and parallel to the medial two-thirds of the inguinal ligament. You have to preserve the spermatic cord and the ilioinguinal nerve, and you have to inspect the spermatic cord for the presence of the hernial sac that could appear pearly white in nature. And where is it located? It is located on the outer side of the cord. And in herniotomy, you are not applying the mesh, you are just strengthening the wall with the help of the sutures. While in the hernioraphy, you have to reinforce the posterior inguinal canal. It repairs the transversalis fascia, which is the posterior most layer of the abdominal wall muscles, and the internal ring when the internal ring is weak and stretched and transversalis is bulging out of it. There are two common methods which could be used in the hernioraphy or in the repair of indirect inguinal hernia in adults where you are using the mesh. That could be the Schuldeis method. The Schuldeis method is when the deep ring and fascia are incised carefully. They are separated from the deep inferior epigastric vessels and extraperitoneal fat. Then यहाँ पे आप you will use the double breasting method. What the double breasting method is? Double breasting of the lower flap of transversalis fascia behind the upper flap of the transversalis fascia. When you are doing what? When you are making one layer with the lower flap of transversalis fascia and another layer with the upper flap of the transversalis fascia. So there are basically two layers or double breasting. The step number 2 would be कि आप conjoint tendon is sutured to the inguinal ligament to make another layer, and then the third layer would be formed by the upper flap of the external oblique aponeurosis, which is sutured to the inguinal ligament. So layer number 1, layer number 2, layer number 3. Layer number 1 by the upper and lower flaps. The layer number 2 will be conjoint tendons, and layer number 3 would be upper flap of the external oblique aponeurosis, which is sutured to the inguinal ligament. And then the second method for the repair or hernioraphy in the adults of the inguinal hernia would be Lichtenstein hernioplasty. Now, as the name suggests, it's an hernioplasty. It means there is a usage of the mesh. It involves the placement of mesh anterior to the posterior wall, and then you are overlapping it in all directions. What does the mesh do? Mesh is basically the thin structure which would promote the fibrosis. And as we know that once the layer is fibrosed, it is very strong as compared to any normal wall. Then you will suture the inferior margins of the mesh to the inner surface of the inguinal ligament. You will suture its medial and superior margins to the internal oblique muscle. The medial end should reach the pubic tubercle, and suture the lateral tail ends to one another around the cord, ensuring that there is a gap left in the mesh for the cord is enough to admit the little fingertip. So what you are doing, you are using a mesh, you are suturing it from all sides, and you make sure that the lateral border of the mesh is tied around the cord, and there is a gap of one little fingertip in that. So here we are just done with the indirect inguinal hernia. Indirect inguinal hernia was the one which was coming out of the deep inguinal ring, and it was lateral to the Hasselbeck's triangle or lateral to the inferior epigastric vessels. While the direct inguinal hernia is medial to the inferior epigastric artery, and it protrudes through the posterior wall of the inguinal canal. It is not coming out of the deep inguinal ring, which was already the opening that was present. It is coming out of the posterior wall of the inguinal canal anywhere but medial to the inferior epigastric artery. It means it will form a newer opening, it will come out, it will come inside the inguinal canal, and then it will move medially. It is always acquired, and always acquired why? Because there was no opening previously, and it has created its own opening there, and it is mostly common in the older men. It rarely strangulates due to its wide neck. It accounts for 35% of the inguinal hernias in men. And then other types of the direct inguinal hernia would be funicular direct hernia and the dual hernia. The funicular direct hernia is narrow necked hernia with a prevesical fat and a portion of the bladder. It occurs through a small defect in the medial part of the conjoined tendon. Operation is always advised. So, whenever comes the funicular direct hernia, it is in the medial part of the conjoined tendon, and there is a portion of the bladder which is herniated. Dual hernia is known as the saddle bag hernia or the pantaloon hernia. It occurs when the direct and indirect tracts straddle the inferior epigastric artery. Now, there is this structure which is called inferior epigastric artery. Medial to it is the direct inguinal hernia, and lateral to it is the indirect inguinal hernia. Both of these inguinal hernias are coming out and they are straddling the inferior epigastric artery, one sac being medial and the other sac being lateral to the vessel. As we are looking at the treatment options of the direct and the indirect inguinal hernias, we have another method which is laparoscopic. Laparoscopic means ports would be made in the abdominal wall, and then we will be doing the repair under the camera. So, laparoscopic hernioraphy is the procedure in which we will be using the laparoscope and we will be doing the hernioraphy. The indications could be primary bilateral inguinal hernias, like the inguinal hernia is not on one side but it's on both sides. Then it could be recurrent inguinal hernias. We have already done repair many times for the inguinal hernia, but now it has become recurrent. And then there could be the femoral hernias. Femoral hernia, we mostly don't do the open hernioraphy for the femoral hernias because there are many different important structures present there. So we try not to touch that place. Then we have different types of laparoscopic herniorrhaphy, that could be the TAP or the TEP. The TAP is transabdominal preperitoneal repair, which involves the attachment of mesh to the floor of the inguinal canal from the preperitoneal space, like from within the abdominal cavity, but in a preperitoneal location. You made the ports in the interior abdominal wall. You entered into the abdominal cavity, and now you are coming from behind the canal, and then you are placing the mesh there. Its major complications are generally anesthesia and the risk of abdominal adhesion at the laparoscopic sites, and obviously the जो incisional sites होती हैं वहाँ से भी hernia could bulge out. Total, then there is totally extraperitoneal repair or TEP. It is more difficult procedure because it entails the inflation of a balloon in the preperitoneal plane to expose the inguinal floor first, and once you have exposed the floor can be laparoscopically repaired using the prosthetic mesh to cover the defect. And that's it for today. We will see you in the next lecture very soon, and we have some lectures lined up which include the femoral hernia, which will also include the Lockwood method, McEvey method, and Lotherson method of repair of femoral hernia, as well as the sliding hernia and umbilical hernia. See you soon.